sensations of your face, particularly sudden, severe electrical shock-like sensations triggered by everyday activities such as eating, talking, chewing, are some of the traditional sensations patients describe. And trigeminal nerve itself has 3 different branches stemming from the nucleus in your brainstem, and those eventually branch multiple times, 3 main branches. One called your ophthalmic, means gets your forehead around your eye. Your maxillary gets more of your frontal face around your nose, as well as your mandibular branch that comes more in the jawline. So patients can be affected in any part of those sort of branches and get sensations and symptoms along those dermatomes.
And I heard a patient one time refer to this as the suicide disease. Obviously, I think that means that it involves obviously severe pain. And I think one of the reasons is that you're not going through that spinal cord modulation of pain. Can you talk a little bit about the severity of the pain
Yeah.
it's come to you with?
Yeah, and it can be quite severe. So just imagine if you had patients describe like an ice pick sensation in your face 24/7, 365. So these are pre-debilitating conditions where just your cognitive ability gets delayed and just dealing with chronic pain on a daily basis from your simple tasks of daily living, just talking, just chewing and living your life. These patients are dealing with this on a daily basis. So there's a ton of medications for it just to manage the pain. There's multiple different interventional procedures that can be quite risky and a lot of complications come of it. But patients do that just because the pain is so bad, trying to basically get some sense of normal life back.
Gotcha. And who's kind of most impacted by trigeminal neuralgia? Men, women, what does this community of patients look like?
Yeah, if you look at the data on it, it's sort of a little bit more favored to women over men by about 55-45 percentage-wise. You commonly in your 40s and 50 age range, but I've seen patients in their 20s, 30s, sort of all about. And sometimes it happens from a traumatic injury, whether it be a car accident, facial trauma, dental procedures, and sometimes just idiopathic where it just pops up out of the blue for no apparent reason. So they haven't really identified specific reasons for it, but it can happen for multiple different causes.
Gotcha. And how does this interface with craniocervical instability? We've got a lot of patients who have craniocervical instability. Do you see overlaps there between those two things?
There is. We're seeing a lot of different overlaps, mainly because your nucleus of your trigeminal nerve is in your brainstem, which is right at that C1, C2 level. So if there is any instability, that dural tension that happens from the instability can damage and irritate these nerve roots. So they're manifesting in facial pain, chewing. A lot of CCI patients also have TMJ dysfunctions. One of those branches of the trigeminal lives right behind your TMJ. So if there's even arthritic conditions or pain coming from there, it can sort of trigger those symptoms. So there's a huge overlap. Plus, your parasympathetic and sympathetic nervous system run through your part of your maxillary branch of your trigeminal. So this can create headaches. This can create a lot of even vagal innervation, so bradycardia or changes with your heart rate. So a lot of overlap in the CCI community.
Gotcha. So interventional neurobiologics, I think that's a term that I kind of coined out from interventional orthobiologics, but the concept here, so interventional orthobiologics is we inject things that can cause healing in that orthopedic musculoskeletal system, and those are precise image-guided injections. So Jason, interventional neurobiologics, and then I'm assuming is the ability to do the same thing, but for nerves?
Very much. So in most of the time, it's going to be your platelet-derived treatment, so platelet-rich plasma. Inside those platelets exists a plethora of growth factors. For nerve-specific recovery and sort of repair, there's several different growth factors involved in that. NGF, nerve growth factor, brain-derived neurotrophic growth factor, and VEGF, vasal endothelial growth factor, are some of the big players. These are all concentrated in your platelets. So the neurobiologics help that nerve recovery from a remyelination, increase blood flow to it, as well as just nutrients to help the nerve recover and heal, essentially.
Gotcha. So I think we talked a little bit about this one. How does this work? So basically, platelets have growth factors. Some of those growth factors are focused on creating new nerves or helping repair nerves. And a lot of that comes from what platelets normally do in the body, right? The issue is that if you have, let's say, a big cut, there's a lot of things that have to be repaired as you bleed into that cut. So you bleed into the cut, the platelets cause a clot, then the platelets orchestrate a repair response, and that repair response is going to include nerves, right? When your big cut heals, usually you can feel there. The only reason you can feel there is there's been some nerve repair. So what is platelet lysate? So how does platelet lysate differ from platelet-rich plasma? Let's talk a little bit about that.
Yeah, from the patient side of things, it's not much different from PRP. You come in, someone will draw your blood, we'll send it to the lab for processing, and then we get it re-injected into you. But what we do from the laboratory standpoint is how we process the platelets. Whole PRPs is basically your platelets are sort of like a slow release time pill. Inside your platelets are those growth factors. But the problem with that, the outer shell of the platelets is extremely inflammatory, so it creates more inflammation. For nerves, we don't want so much inflammation, so we are able to, in the laboratory, bust open those growth platelets, just extracting the immediate release growth factors, so we can concentrate those, filter out all the outer shell of the platelet just to get to those growth factors. So it's less inflammatory, as well as its immediate release growth factors for the nerve to help repair without so much of a flare-up. If you've ever had PRP for a tendon ligament, it gets pretty pissed off for the first 48, 72 hours. This sort of eliminates some of that to some degree, as well as it accelerates that healing potential with putting the growth factors, concentrating them directly onto the nerve itself.
Gotcha. And at Regenix, we've done a lot of research on increasing growth factors. So let's talk a little bit about, because I think this is something I just did some videos on, a releasate, which is where you clot something and you have it release growth factors. You take the plasma that has those growth factors versus a simple platelet lysate. You freeze it versus what you're using. What are the differences there in growth factor content between the three things?
Yeah, from a growth factor profile, we want the highest possible growth factors. Those releasates and some of those early sort of generations of platelet lysate that we used to use as more of a low-level growth factor concentration. But as we've developed different ways to increase that concentration, now we're able to actually really concentrate those growth factors to a very high level, where before we were more of the lower level, just to maximize our outcomes and improve our regenerative capabilities from the lysate. We want as much growth factors as we possibly can, just to saturate. There's receptors that these growth factors go to. We want to be able to maximize our saturation. So if you have a lower concentration of those growth factors, it basically doesn't saturate as much of the receptors, so therefore you don't get as much healing. So if we can maximize that saturation, and that's the beauty of our third generation platelet lysate procedures, where we're able to maximize that.
Gotcha. And just some housekeeping here. If you're just joining us, thanks so much for watching. We're going to do a short interview. I'm going to get through these questions that I have, and then obviously we'll take your questions about this topic or anything else at all. In the meantime, realize that if you want to pay it forward to the CCI community, if you want to pay it forward to the Trigeminal Neuralgia community, please like, share, subscribe, because that's how more patients like you can find this material. And that's how you pay it forward to other patients, right? You may have stumbled upon this. You may be here because you're every week and you enjoy this content, but there's lots and lots of patients out there who don't have access to it. They've never heard of it. They've never seen that a doctor gets online here once a week and answers their questions about these topics. So they're not going to be able to do that unless you like, share, comment, subscribe. So let's get into now the IGNI trigeminal neuralgia procedure itself. So image-guided neurobiologic injection is the IGNI part. And tell us a little bit about this procedure, how you got involved in doing this, and how it kind of evolved from there.
Sure, it started probably about 5-7 years ago. A patient presented with trigeminal neuralgia, dealing with it for chronic years, and have had different procedures like gamma knife, radiofrequency ablation, and complications of those, like after our radiofrequency ablation, burning of the nerve, it left her entire face basically paresthetic or dysesthesia. So she had numbness in her entire face because of that. So, as well as on a host of medications. So she came with us asking us this, like, hey, can you treat this? At first, I was a little resistant, but it took me probably about a year and a half to further look at some of the research, develop different techniques, understanding the pathway of the nerves, and how get it really from interventional injection, how can we precisely target this in an image guidance perspective. Started very simple. I've gone through probably 4 or 5 different iterations of the procedure, and now we're able to take these biologics and precisely inject it into and around these nerve roots where they're being damaged, whether it be the maxillary nerve, sphenopalatine ganglion, inferior alveolar nerves, as well as several other different pathways around those. So we're continuously developing different techniques on how to do this, and it's a process of any kind of, as you know, the PICL procedure has been a 15-year process for yourself. So it's definitely in its infancies, but we're starting to get some traction, seeing some excellent responders to what we're doing. So it's motivating us to continue that development, because really this patient population doesn't have a whole lot of other options. There's a lot of pain control medications, but nothing addressing the underlying issue, which this is essentially helping to do that.
And I know from talking to our rad techs, just so people know, we work with rad techs. They set up our images for the fluoroscopy guided. Obviously, when it comes to ultrasound guided procedures, we do that. The doctor runs that probe. But when it comes to CR and fluoroscopy, we work with a rad tech, and we train the rad techs on how to set up these shots, because some of them are quite complex. And I know just from talking to our rad techs that work with you on this procedure, it's not easy setting up these shots. Can you go into that a little bit, and how complex it is to see these small little targets that you're trying to find?
Yeah, so one of the access points for trigeminal nerve is called Meckel's cave. There's small little foramens on the base of the skull. Foramen just means holes where the nerves exit, similar to like your spine if you're doing an epidural. But in the bottom of the skull exists several different small holes. So it takes a very technical patient positioning, understanding in the anatomy, as well as understanding fluoroscopy to maximize this image, so we can guide the needle directly to where it is. And it's taken a long time to train our rad techs to understand the anatomy, understand what we're looking for. So it's definitely nothing you can just jump right into. So it's taken some time to develop, from the rad tech standpoint, image guidance, as well as on my end to educate them on sort of how to do this. And luckily in our clinic, we've got a 2 C-arm setup, so we can triangulate that quite easily now that we understand everything. But yeah, it's definitely a pretty highly advanced image guided technique in very small margin of errors, meaning this is a high network and high sort of risk procedure if you don't know what you're doing. So the base of your skull, you've got your carotid arteries, you've got your ophthalmic arteries, you've got other different nerves, as well as vessels that you need to make sure to avoid to do this safely.
Yeah, and just so people know, biplanar fluoroscopy is what Jason's talking about. So that's one X-ray unit coming this way, that's one X-ray unit coming that way. And that allows you to instantly see from a 3D perspective where that needle is. A lot of times when people just have one C-arm, you're constantly flipping from AP to lateral, AP to lateral, AP to lateral, going back and forth. And it reduces your accuracy quite a bit because there are a lot of times that you just don't flip to the other side because you're like, well, I'm pretty sure I know where I am. And it's a pain in the neck to reacquire the image every time we move that C-arm. So if you've got two that you can use at the same time, it allows you to really improve that accuracy because you're not spending that additional time to reacquire the image. Because when you move it from AP and then you go to lateral, you've got to futz with it a little bit to make sure you get a good lateral. And you move from lateral to AP, you got to futz with it a little bit to make sure you get a good AP. So what kind of results have you seen with this so far? Let's go into that. Give us, some of your more interesting results that you've seen, patients that have walked in with X, and then how has this changed their lives?
Yeah, I've seen a plethora of different situations. I've seen a couple younger cases that actually developed trigeminal neuralgia after like a viral infection. One had COVID, like confirmed COVID. Another just had upper respiratory sort of viral syndrome, started attacking his nerves. There must be some sort of cross-linking similar to like the shock protein in COVID that affects nerves. We treated them. They were dealing with this for probably about 2 or 3 years. Nothing really touched it. We treated them once, got about 80-90% of the pain to resolve, which was fantastic. And then we've got on the other side of the story, we've had patients dealing with some chronic issues like chronic TMJ joint arthritis, which I mentioned that one of those branches lives right behind your TMJ joint. So even the arthritic conditions, you talking, chewing, creates inflammation around that nerve. So we were able to basically resolve his symptoms, but we can't cure the arthritis. So it's something we're maybe doing on a yearly basis, a small treatment to sort of keep his symptoms at bay, because similar situation, talking, chewing would create severe pain. So medications wouldn't really touch it. So this has actually been a somewhat of cure for him, where we're able to allow him to live his normal life with his grandkids, with his family, eating whatever he wants, talking as much as he wants, and just living his life. So it's been rewarding in that sense, where we can get people back to sort of just living their life on a day-to-day basis without thinking or dealing with this pain. It's been pretty rewarding on my end, where it's like, great, we're finding a solution for something that really didn't exist before in helping patients.
Gotcha. And if you're just joining us, we'll be getting to taking patients' questions here in just a few minutes. I've just got one or two more. Have you seen any CCI patients in your patient population?
We have. We've seen several of those ongoing treatments. Depending on how severe the CCI is, how long they've been dealing with the problem, earlier treatments seem to respond quite better. If someone's had it for chronic issues or even like hypermobile EDS populations, that becomes a little bit more resistant, harder to treat, similar to what we find for CCI or just any orthopedic issues in that patient population. But we have seen some mixed results in that patient population.
And then let's start going to some patient questions here. Lindsay, can I get both sides of my face that have trigeminal neuralgia along with the PICL procedure, or do these need to be scheduled separately? Yeah, Lindsay, normally what we'll do is we'll treat the CCI first, and many times the trigeminal neuralgia component goes away when we stabilize that area. Now, if it doesn't go away, then I would refer you to Dr. Markle to do this very specific trigeminal neuralgia treatment, but usually it goes away. Now, Jason, do you normally do bilateral treatments or just unilateral?
It depends on how aggressive we want to get, but usually start with unilateral that first time just to see how the patient responds to it. You don't want to go, anybody that's had any chronic sensation of nerves, too much at once can be a little overloading. So we can exacerbate some of her symptoms, which obviously isn't ideal. So usually we go a little bit slower, do once, probably unilateral, see what kind of results we get. And if everything's going well, if unilateral is taken care of, then we can go to the contralateral side or the other side. Or if it's partially helped at that point, they've responded well without too much of a flare-up, then we can think about doing bilateral.
Gotcha. Atypical trigeminal neuralgia, that doesn't ring any bells for me, maybe for you. Any sense there?
Yeah, so atypical facial pain. Just basically something doesn't fit into the box of trigeminal neuralgia itself. Sometimes their symptoms are a little bit different, disconnected, but usually still getting facial pain. We were able to, and that's where the full history, physical examinations, try to come up with an identifiable area what's causing your symptoms so we can start targeting that specific branch of that trigeminal nerve.
Gotcha. If patients already have autoimmune disease and MCAS, will they be able to be treated for trigeminal neuralgia?
Yes. Again, autoimmune disease patients as well as MCAS sort of fits in that hypermobile EDS spectrum. And we've treated several of those without too much of an issue, treat multiple of these patients as well, just from an orthopedic standpoint, and they typically respond quite well, again, to platelets. And a lot of those patients are very afraid of the inflammatory responses of something like PRP. That's where the beauty of the lysate comes in, where it's not as inflammatory, and we can get rid of that inflammatory shell, the platelets themselves. So most patients tolerate it quite well.
Gotcha. Okay, well, I think that's most of the questions on trigeminal neuralgia. Jason, thanks so much for joining us today. I'm going to get into my normal answer 100 questions in an hour mode here. And because I'm getting a bunch of questions about a bunch of different things. But thank you for letting us know about this. And as I've said, if you have trigeminal neuralgia, then consider this kind of treatment. Now, if you've got CCI, we normally treat the CCI first, see if the trigeminal neuralgia goes away. If it doesn't, then Dr. Merkel can help you with this stuff. But thank you, Jason, for joining.
Thanks for having me, guys. Thanks so much. Have a great day.
Okay, guys, so I'm going to get into our normal Q&A stuff here. Start with Alexis. If hydrodissection does not relieve occipital nerve pain, what might that indicate? Well, could be a couple things. Number one is it depends what you do the hydrodissection with. Is it corticosteroid? Is it anesthetic? Is it a platelet procedure? How concentrated are the growth factors in that platelet procedure? If it's one that we did, then it's going to be ultrasound guided with high-dose platelet lysate. And if that doesn't help things, then there's probably something else causing the occipital neuralgia. One of the things that it's hard for patients to realize is that occipital neuralgia in the context of CCI isn't really a diagnosis unto itself. It's not the branch or the trunk of the Christmas tree, it's the ornament on the end of the branch. And what I mean by that is that there's usually that this is caused by craniocervical instability, which is then causing the suboccipital muscles to get overly tight and go into spasm, and then you get irritation of the occipital nerves. So you still have to treat the main cause in that case. Alexis, can instability in the low back SI joint cause dural pull all the way up to the neck? Certainly possible. I think, again, one of the things that everyone kind of has on their mind right now is this concept of occult tethered cord, this idea of dural pull. And while I think dural pull can be important, it's probably not as important as most patients believe, meaning that there's huge crossover between neck and low back issues. And from a biomechanical standpoint, the low back acts as the base of support of the SI joints, act as the foundation of the house, if you will. And if the foundation has problems, then the walls develop problems, the roof develops problems, i.e. you get problems all the way up in the neck and vice versa. So we frequently see lots of comorbid conditions between neck and back pain. Doctors don't like to think about that, right? Because that takes additional time. That additional time is very much focused on, well, tell me what you're here for today, right? You've seen doctors do that, and they want to hear one thing because they got 40 patients to see. They don't want to hear it's your neck and your upper back and your low back and your right knee, because then that's 4 different things they have to examine, and they got 40 more patients to see. So just realize that there's huge comorbidity between the neck and the back. They're often seen together. They talk back and forth to each other. There are neural connections and neural tension connections, but there's lots of biomechanical connections there too. Lindsay, have you treated patients with damage to the vagus nerve, trigeminal nerves, and CCI? Yeah, Lindsay, that's a fairly common collection for me. I've certainly seen patients with damage to the vagus nerve, meaning vagus nerve type symptoms, trigeminal symptoms, and CCI. And what percentage of my CCI population has all 3? I'd say probably 1 in 5. So it's not uncommon at all. Jessica James, for those that cannot travel at the moment, opinion on Dr. Sebastian Quezada in South Florida. Yeah, I've looked at this guy's website. I think he's a mid-range trained spinal provider. And any of these upper cervical injections are highly complex procedures to perform, as I've said before. So if we're talking about C01, meaning the very top joint, or C12, I don't recommend anyone outside of Colorado, simply because those procedures are too high risk and too specialized. And unless you do them all day, every day, there's a risk of hurting the patient, which is quite high and quite severe. I think I've told you all about, the injuries that have happened here, where, on the East Coast, a case that I got involved in, because it was a patient I had seen, who then went to see this doctor. They were told, don't get this upper cervical procedure outside of Colorado, especially for this patient, because the patient was very hard to position. The doctor got a little confused, stuck the needle right into the brainstem, injected, and obviously this person, who was already pretty disabled, got much more disabled by injecting directly into the brainstem. So again, this is in this same category. Now, if you're talking about just getting routine ligament injections or C2, 3, 3, 4, 4, 5, all the way down injections, then I'm sure this provider would do fine. But if we're talking about high upper cervical work, which is what we're often talking about in this patient population, that's not something I would go outside of Colorado to get, simply for the reasons I've brought up now many times. Jessica, how soon can a patient get PRP after a PICL? Technically, there probably isn't a limit of more than a month or so there. There might be other technical things that might prevent that, right? One could be, let's say the patient's anemic, in which case they might have to build their blood density back up. Or other technical things could be, it's a very sensitive patient to any kind of procedural-based care, in which case you wouldn't want to do a PRP injection after PICL. You'll probably just flare the patient up. Having said that, I put about a month in there. And again, incredibly important. PRP does not equal PRP, does not equal PRP. So just because a provider says they can do PRP on your neck does not mean that what you will be getting is what we would do at Centeno-Schultz, meaning the likelihood that you're going to get a far inferior procedure is high. They're not going to have dual access x-ray. They're not going to have digital subtraction angiography. They're not going to have experience injecting the high upper cervical spine. So just because some doctor says they're doing PRP in the cervical spine, that might be completely different than what you could access if you were at our clinic. Lindsay, I think I got that one already. Snowmass, if you have pulling sensation under your eye, what nerve is responsible? How can the address be a regen? I need to know a little bit more about that pulling sensation. First thing I'd probably ask, and the first thing that comes to mind, that's obviously a bigger blanket question, is is there scoliosis involved, right? One of the first things we see is when there's side bending in the spine, that side bending causes rotation. So you could get asymmetrical pulling, for example, on the occipital nerve itself, which is the main nerve that goes to the eye. It might be an infraorbital nerve issue, which has nothing to do with that at all, in which case that could be how to dissect it out. But that's one that's going to take some looking at imaging, history with the patient, doing hands-on exam to figure out what's probably causing that pulling sensation. John, what is your main approach for ankle PRP? Yeah, John, it just depends on what's wrong. Remember, so this is a really, really good thing to think about here, right? If we're talking about just the ankle. So I'm going to list off, just off the top of my head, all the different procedures that an advanced interventional orthobiologics practitioner would deal with in the ankle. So we're talking about an ankle tibio-talar joint injection, intra-articular. We're talking about an ankle subtalar joint injection. We're talking about an ankle talar joint injection. Are we talking about the ATF, CF, or PTF ligaments of the lateral ankle? Are we talking about the deltoid ligament? Are we talking about tibial nerve hydrodissection? Are we talking about peroneus longus tendon sheath injection or into that tendon? Are we talking about Achilles tendon injection to the sheath or into the tendon? So as you can see, that's just the ankle, guys. If we were to go through every joint like that, there's about 20 different procedures that can be performed in every single joint. And the percentage of providers out there that can do all 20 of those procedures that claim to be able to treat ankles with quote, regenerative medicine is less than 1% of the providers that you could see could do all of those procedures I just described. But all of them are on the menu, right, for any patient that walks in with an ankle problem. So very important to realize that your ability to access providers who can give you the full menu of what you might need is extremely limited. So that's our approach for ankle PRP, but those are just that's just the menu of the different procedures that can be performed. Obviously, everyone is different. Some patients would need certain procedures and others not so much. Sherry, is a relationship between TMJ, CCI, meaning would it be more common in CCI patients? Yeah, Sherry, we see that all the time. Very, very common to see TMJ and CCI patients. Again, that's due to overuse of the anterior musculature here. That anterior musculature is a big player, if you will, in stabilizing the head on the neck. So when these high upper cervical muscles go offline, the anterior strap musculature in the front can take over. That can overload the TMJ. And I'm going to continue answering questions here, but while I do, I am going to put this up because, again, as you know, I do this once a week here. I answer your questions in kind of rapid fire succession. But I also answer questions 7 days a week on RPICL on Reddit, which is right here. So if you go to Reddit and you type in PICL, this comes up. And so there's now hundreds of questions on here and hundreds of patients on here who are answering or asking these questions. I get on and answer them in writing. I'll refer to various references or I'll refer to a video. So it's another opportunity for patients who are a big fan of this format. Hey, I get to ask these questions right to the doctor, to actually go onto someplace where I will answer these questions in writing as well, 7 days a week, not just sort of rapid fire like I do here 1 day a week. Cassian, would higher dissection that merely separates the SCM from the carotid sheath suffice for vagus nerve treatment, or does the injectate need to pierce into the carotid sheath and separate the vagus nerve itself, probably? So yeah, it's a very good question. I don't think we know the answer to that question yet. The good news is that these fine sheaths that surround nerves are extremely permeable to the type of growth factors that we're talking about. So it's probably initially a better idea to do the hydrodissection, not so much between the sternocleidomastoid, but extra sheath. Now, I can tell you in most of the patients we see, the sheath itself isn't there, meaning the sheath, I think, is something that we see in cadaver dissections. But I can tell you from hydrodissecting many of these out, we see the platelet growth factors, even if you're not trying to pierce the sheath, go right in between all of these structures, right around the carotid artery, right around the internal jugular vein, right around the vagus nerve. So I think these sheaths are probably not present or intact in many of the patient population that we see. So it's kind of a moot point based on what's actually seen clinically. Casein, will there be a role for 5% dextrose? You wouldn't want to add 5% dextrose to PRP. This is one of the, if you really want to find a PRP novice, that's someone, or a bone marrow concentrate novice, that's someone that's using hypertonic dextrose around orthobiologics. So for example, the kill rate of mesenchymal stem cells with 5% dextrose is not a lot. It's maybe about 20%, but it's still killing 20% of those cells. We've done that original research. I probably don't have time right now, but I'm happy to dig up those old graphs that we created about 12 or 13 years ago. If you increase that to 10%, you get a kill rate of about 60% of the mesenchymal stem cells are now dead with a 10% prolotherapy solution. If you go up to 15%, so again, 10 to 15% is what's normally used, the kill rate's like 90%. Same thing with 5% or 10% dextrose around platelets. You're going to create what I call platelet raisins, meaning you're going to dehydrate the platelet. So not a good idea to use those things together. You can certainly use 5% dextrose. That probably has some neurolytic effect, and that has been used around nerves with good success. But you wouldn't want to put 5% dextrose around platelets, because then you're going to probably damage your platelets. Snowmass, can burning mouth syndrome be treated, and how? Burning mouth syndrome, that's a new one on me, meaning that that's kind of a box that a doctor would put someone in, but I would need to know specifically what's causing the burning mouth, meaning are we talking about a cranial nerve 9 issue, which would be the back of the mouth? Are we talking about a tongue-based issue? Are we talking about the roof of the mouth? What nerve is involved here? And that would be able to tell me more about how to treat that. But burning mouth syndrome is just some artificial box in which doctors can dump patients into to give them a diagnosis. But like everything we do here, it all depends on a specific diagnosis. What's specifically causing that problem? And then that leads to specifically what needs to be treated to solve that problem. John, I have a patient with weakness and pain in the left shoulder and triceps. MRI came back with stenosis at 5/6 and a syrinx at 7. Can syrinx cause any of his problems? Well, syrinx is going to be a central cord syndrome. So I would say that you'd want to look at, does this patient have central cord type issues or problems? And that's a very distinct type of exam, and that would help you to differentiate one from the other. Another way to easily differentiate one from the other is to try to see if you did a 5/6 epidural, for instance, with platelet lysate, can you get rid of those symptoms or not? And if you can't, then maybe there's more weight on the syrinx side, because those growth factors are not going to be obviously getting into the syrinx area or into the internal cord. So those are some things to think about as far as piecing those teasing those things out. Lindsay, if patients have autoimmune disease and MCAS, will they be able to be treated for trigeminal neuralgia? I think we got that one already. Bonnie, Dr. Markle is top notch. Great to hear, Bonnie. He is top notch. Just so that people know, in order to work at Centeno-Schultz Clinic, so if a doctor from Harvard applied tomorrow to Centeno-Schultz Clinic, having completed a spine fellowship at Yale and having done their PM&R residency at Harvard and their medical school at Stanford, they would be denied access to the clinic as a treating doctor, meaning we would not hire that doctor. Now, why wouldn't we hire that doctor? In order to work at Centeno-Schultz, you have to complete our 1-year fellowship. Now, that doctor would certainly be a candidate for that fellowship, but that doctor, despite all of those wonderful credentials, doesn't have the ability and the knowledge to work at Centeno-Schultz Clinic, because the amount of information that doctor knows about interventional orthobiologics or neurobiologics is zero or close to zero, because they don't get that stuff and exposure in residency or fellowship for that matter. So again, it's important to realize that Dr. Meckel works at our clinic because he went through our 1-year fellowship and then stayed on. But again, that doctor who went to medical school at Stanford, did his PM&R residency at Harvard, and then did a interventional pain fellowship at Yale is not qualified to work at Centeno-Schultz right now until they go through that fellowship. Centeno-Schultz clinics been advanced by Harry. If I've been diagnosed with TMJ, would there be any positive or negative consequences from TMJ surgery for neck stability in the future? Probably not, Harry. I think the biggest thing you'd want to really look at there is head positioning. And I always talk to patients about this. If you have craniocervical instability, you have to be extraordinarily careful about getting procedures in the entire head and neck region, right? At the end of the day, the reason why you do is because those doctors are doing what they need to do to maximize their exposure. So for example, that might be turning your head like this, because that maximizes the exposure to the part of the TMJ they want to get into. And then after that, that might be moving your head like this, because that maximizes the exposure into the part of the TMJ they want to get into. So just be very, very careful there. That's something I think you should discuss with the surgeon. What head positions will you have me in? I think and I've recommended this to a lot of CCI patients, wear a hard collar into the procedure and make sure that they're not allowed to take the hard collar off. Or even if they can take it off, it just reminds the entire surgical team, hey, this guy's got a really bad neck. We got to respect that, because they're not going to be thinking that way. You know, they might be seeing 5 patients that day and doing this procedure or similar procedure in 5 different patients. So you got to be able to stop the surgical team and make sure, number one, that you know what positions they're going to put your head into, and can you tolerate that? And then number two, you got to have some way to shake them up a little bit and say, this patient is different. So I would recommend wear a cervical collar into the procedure so that they can all say, oh, okay, God, this guy's got a neck issue. We may not be able to do with this guy what we would normally do with other patients. Rishi, sorry, I didn't get this one out to Dr. Meckel here. Trigeminal cervical convergence, I've certainly heard of. So yes, I think it's certainly possible to go ahead and see occipital neuralgia that looks like trigeminal neuralgia, basically is what we're talking about here. Lindsay, what can patients do before their procedure increase their odds of success? Lindsay, I think you're talking about PICL. And for PICL, we've got a 14-page document on that. And this is something that comes up a lot. I really want to make sure that everyone knows this, because let me share it here. I'll get off of this for a second. I want to make sure that everyone that's one of our patients or is going to be seen by us knows that this 14-page document is out there, right? So this is the, 11-page documents, version 14. So it's an 11-page document. Got to change this because this is version 14. That goes through before your PICL procedure, right? And each one of these are things you're going to have to initial, but we send this to you beforehand. So as you can see, lots and lots of information about before the procedure. The day of your PICL procedure goes into what to expect, what are some things to think about for that day. Then immediately after your PICL procedure, again, lots and lots of information about medications you can and can't take, about the first 24 hours, the first 48 hours, what to expect in the first couple days, what if you have an emergency, what if you need to go to the emergency room, how to get in touch with your doctor, on and on and on. This is I update this document frequently, and then longer term after your PICL procedure. So again, all of this information is in there. So Lindsay, if you're signed up for the procedure, we'll send you this document, and it will go into that in more detail than I think you'll ever want to see. I think this document is taken on a life of its own. Whether that's a good idea or a good thing or a bad thing, I don't know, but it's all in there. So just realize. Christy, are these newer procedures for processing the plate similar to what's happening at the Centeno-Schultz clinic? Yeah, this is Centeno-Schultz clinic, Christy. So yes, these are newer third generation platelet lysate. So that's a higher growth factor platelet lysate when compared to releasates or PRGF, or compared to just freezing platelet-rich plasma. SNOMAS, if you do PRP on TMJ, then you can do PICL 2 months later. You could, but probably makes more sense just to do them at the same time. We would normally do the TMJ joint and ligaments with bone marrow concentrate, which is going to be more powerful than PRP anyway, if we're doing a PICL. So it probably makes sense to just do them all at once. Probably be more cost effective that way too. Crymology, hit the like and share out. Yep. Again, guys, if you want this information to get out to more patients like you, for every one of you out there right now watching, or who are going to watch this later, there are literally 100 patients who have no idea that this information exists, who will never come in contact with this information because there aren't enough likes on this, or it hasn't been shared enough, or whatever other crazy algorithm all of these social media sites use. They're all driven by that same thing. If you guys show interest in this by like, share, comment, subscribe, obviously you're commenting quite a bit, then the algorithm pushes it up, and some of those 100 patients can get access to it. Lindsay, are all the branches of trigeminal nerve able to be treated? They are, Lindsay, I know that. Andrea, in the results of the CCI symptoms questionnaire, I don't see leg and arm pain. If someone has CCI and a bulge that touches the spinal cord inflection, these symptoms can be assumed be from the bulge. Yeah, Andrea, that's something we always look at. Now, the CCI questionnaire is very, very focused on upper cervical symptoms, because its job is to help me to try to determine, am I looking at and dealing with someone who has more upper cervical symptoms, or is it coming from that bulge, let's say, in the lower cervical spine? Now, frequently, when we see a PICL patient, we'll treat both, right? That's not a problem. So I'll treat the upper cervical spine with PICL, and then I'll also treat, let's say, if it's a 5-6 bulge at the same time, because we believe very much in that whole body approach. I don't believe in parting out the body and just the upper neck and the lower neck and the right shoulder and the right knee, etc. I believe in treating everything I possibly can within reason, number one, and then obviously the patient's got to be able to tolerate it. That's something we talk about a lot here. For craniocervical syndrome, do you recommend posterior versus PICL? Do you offer BMC posterior? So again, craniocervical syndrome, let's start there. Craniocervical syndrome just means that the upper neck is causing symptoms, but there's no instability, or instability isn't driving that bus. And CCI, craniocervical instability, is the upper neck is causing symptoms, and instability is driving the bus. So, so when it comes to craniocervical syndrome, those are very specific X-ray and ultrasound guided procedures to get into those upper cervical parts of the upper cervical spine that are driving symptoms. So the answer is we don't do PICL there. We just treat those structures. So that's what you guys would call a posterior injection. We can do bone marrow posterior for sure. We do that all the time. And again, if we're doing PICL, we do a lot of bone marrow posterior work. Realize that when we're doing PICL, we're almost always treating the posterior part, meaning back here, after we treat up front. Again, if you're just joining us, you might be wondering why the heck is he showing this RPICL thing from Reddit. This is where, if you go and join this community, this is where I answer questions just like this 7 days a week in writing. And what I'm trying to create here is a massive Q&A section, right? Because I can go into RPICL here and let's see, someone is asking about trigeminal, right? So let's just type in trigeminal. And here's all the different stuff that comes up that I've answered before about trigeminal. Or let's say someone's talking about occipital nerve, right? And they're concerned about that. You can type in that, and this is all of the questions that I've already answered about occipital nerve. Or you can come in here and talk about Botox, right? Let's say you're concerned about Botox and CCI. And there's all the questions and answers that have come out on Botox. So this is a massive, massive developing Q&A section where at 3 in the morning, if you want to know about Botox, you can go in there and find that out. And I want everyone here to go and join this because that allows you to help other patients, right? They're also going to have questions that they want answered by a doctor, an expert in this area. So join our PICL before we get too much going here, and that's on Reddit. Crimology, I receive Xeomin injections for facial trigeminal pain. That's an interesting one, Xeomin. That's not one that I have seen before. Oh, it's Botox. Okay. Yeah, so it's basically Botox for facial pain. Botox is not good for CCI patients in general. Most CCI patients will flare up if they get Botox injections. That's because they need that spasm. Now, having said that, there may be some things that this is providing relief separate from its ability to relax muscles, because we see that with botulinum toxin A. There's another botulinum toxin A product on the market that's very good called MyoBlock, that's very good at controlling pain. That's separate from this. So at the end of the day, opinion on growing that root, it's not helping anything, right? It's not treating anything. It's just a pain relieving mechanism that lasts a certain amount of time. So I think the goal should be diagnosing what's wrong and treating what's wrong to try to get a more permanent fix. Lala, hello, doctor. Can we have a minor misalignment of the AO joint without the ligaments being damaged? How can we see that, and what tests? Can we remedy it with gentle physiotherapy even if it takes longer? Yeah, so Lala, it's certainly possible to have a minor misalignment without any ligament damage, meaning these joints are built to move. So you're going to see those sorts of things. That's AO or nucleochiropractic. And then obviously physical therapy to build strength. So I would always recommend that you try conservative methods before anything else. And you want to make sure you fail those conservative methods before we go down the direction of more invasive care than just upper cervical chiropractic or physical therapy. It's been advanced by Harry. If you yes, we do that all the time, Harry. We treat both TMJ and CCI in the same visit. I would say that in about 1 in 5 PICL patients, I'm also treating the TMJ at the same time. Lisa, you guys, it's so exciting. I wonder how it will progress. CVS will how this will progress CVA patients in the future. Could time and age of injury affect the nerve injury, affect the regenerative healing? I think you're talking about stroke patients. That's going to be a little different than what we're talking about, right? That's going to be a central nervous system injury. But I do think, listen, I think that we've already seen interventional cardiologists, for example, and interventional radiologists who have used regenerative medicine to try to deliver it into specific parts of the body, specific parts of an organ, going through an artery, for example, in a specific artery. You can do that in the brain. And I think that we will see those kinds of treatments in the future for stroke patients, for example. So if you can target a specific distribution in the brain, my guess is we will see stem cell-based treatments, platelet-based treatments, et cetera, that'll be delivered specifically via interventional cardiology to that specific blood supply of that part of the brain to try to regenerate or help that part of the brain heal. I think that is coming down the pike for sure. Submitted advanced by Chiari. Is there a possibility that TMJ could lead to CCI? Probably not. It's usually the other way around. So I think it's probably going the other direction. Lisa, the PICL procedure and also an epidural and lumbar spine, amongst other things, 3 weeks ago. Just wonder if bone marrow construct was used or platelet lysate for the epidural. Yeah, Lisa, not bone marrow for the epidural, because that would really, really piss the nerves off. Bone marrow is pretty pro-inflammatory. Platelet lysate is anti-inflammatory. So anytime you stoke up inflammation around nerves, it's a bad day for everybody. And so we don't use bone marrow construct for that reason around nerves. So it was platelet lysate for sure. Rishi, Dr. Markle, when I press on my occipital nerves and suboccipital muscles, I feel intensification of sinus pressure. Yeah, I think, well, a couple of things here, Rishi. One is that realize that in patients who have chronic pain, we frequently see this bleed over between nerve territories, meaning that one nerve territory can bleed over into another. So if you activate one that's not usually connected, it activates another. So that's a known issue in chronic pain. Separate from that, you've got the V2 trigeminal nerve, which supplies the inside of the sinus area. So it's certainly possible that you may have separate irritation of the V2 trigeminal nerve or that maxillary branch, which goes to the sinuses. And by pressing here, you're doing that crossover nerve thing that is super common in patients with chronic pain, where one nerve territory usually is completely separate from another, but they start to bleed together in chronic pain patients. So you can activate one and then activate the other. Lindsay, have you treated someone who has severe tailbone nerve pain? We have, yes, Lindsay. Lots of different strategies, things to look at there. Sack Lane, thanks, Dr. for all this good information. God bless you. Oh, thank you so much. Yep, try to get on here as much as I can to answer questions. Again, go join this community on Reddit at our PICL so you can get your questions answered there, because these are great, right? These Facebook Lives are great. Patients can watch these. They can listen to these without having to watch them. It's almost like listening to a podcast, I guess, if you will. But I've heard from patients who have more auditory processing issues that sometimes it's hard for them to get this rapid fire format. And for some patients, it's easier to do the written Q&A. So that's what this RPICL is. Just look at all these patient questions I've answered so far. I mean, this thing just goes on and on and on and on. And you can search all of these at any time. So please go and contribute to this community, because this is what leaves the legacy document long after I've retired a couple of years from now. That RPICL will be out there with, hopefully by that time, 10,000 questions and answers that people can go on and find. Bo, can there be possible considerations for a patient who's not skeletally matured or receive a PICL? It's not possible posterior. Yeah, Bo, that's a hard one. We don't know how things like bone marrow concentrate, PRP, and ligaments affect skeletally immature patients. And what Bo is talking about is, let's say, a 9-year-old, right? They haven't grown up to their full height. Having said that, I've done that in 1 or 2 patients when the only other option has been an upper cervical fusion, which is probably even higher risk in a skeletally immature patient. So we would consider that on a case-by-case basis. Charmaine, what's been your observations on the extradural approach to filum release versus intradural filum resection and diagnose? Not tethered cord, Charmaine. I know you guys are used to saying tethered cord. It's a cult tethered cord. A tethered cord means that the conus medullaris, the bottom of the spinal cord, is pulled down. That's not what we see in a cult tethered cord. Listen, Charmaine, I'm just going to tell you the same thing I've told everyone on this. I think about probably 1 in 10 of the current patients that are getting filum releases need filum releases. And for that 1 in 10, it's a fantastic option. But for the 9 in 10, they probably have separate low back issues that are not being identified by the treating neurosurgeon because it's going like this, meaning they're not used to identifying those non-surgical things that can be treated. It's not what they do. They do surgery. And that the vast majority of those patients that are getting these filum releases can be easily treated by treating their low back or SI joint issues. Not taking the additional risk, whether it's an intradural or extradural. So intradural, extradural, it's the same concept, right? It's far too invasive a treatment for the vast majority of patients that are getting it because you can treat them with much, much, much less invasive care and have most of them respond. It's been advanced by Carolyn. What is the average waiting time between sending and imaging for review in a PICL procedure? That's an interesting one. I don't know the answer to that, Carolyn. I can tell you just about a month ago, I opened up another PICL day. So there's a little bit more flexibility in the schedule right now. That flexibility will probably be disappearing here by early March, would be my guess. And then the schedule will get backed up again. So this is probably a good time to submit something like that. The process is that I pre-review those. And by pre-reviewing those, I'm trying to make sure that patient likely has CCI and or has the right information so that we can get to CCI if it's there. So probably about half don't make it through the pre-approval process because the patients don't have enough to get to a CCI diagnosis. So it's kind of a waste of their resources, right? We're charging for those telemedicine visits. But I would say right now, if you did that, far, far less, maybe 3-4 weeks, than if you did it in mid-March, where it's probably going to be 3-4 months. And all of that's because they opened up another PICL day, so there's a little bit more flexibility in the schedule right now. But again, by the time we get to early mid-March, that flexibility is going to be gone. Lisa, I'm referring to neurobiologics in the future of stroke rehab. Yeah, I would agree, Lisa. Listen, I think there's lots to be done there, as I talked about, for sure. Ulrika, can a nerve block at maybe the C2 nerve root irritate the trigeminal nerve? Not usually, but there's certainly convergence there between the upper cervical nerves and the trigeminal. I think someone brought up the ALCAO complex. Let's go to my YouTube channel here. YouTube channel, view your channel. And so if you look at this one here, the ALCAO and the trigeminal nerve, this is a good one to look at because this talks about this plexus that has a lot of inputs and outputs. And this is a relatively newly discovered plexus in the last couple of years. So is there probably some connection there? There probably is some connection there between the C2 nerve root and the trigeminal nerve. But this would be a good one. This would be a good place to start that journey on trying to research that. Can cervical scoliosis or curvature be from ligament laxity? Yeah, so I think what you're bringing up, not so much ligament laxity, but realize that the upper cervical spine provides position sensor proprioception for the rest of the spine and body. So if your body believes that this is straight up and down, and it can with an upper neck injury, then you're going to go through what's called the riding reflex. So you're going to move your body like this to be able to keep your visual field parallel to the floor. And obviously that's causing scoliosis when that happens. So mild scoliosis can certainly be initiated by an upper cervical injury causing abnormal proprioceptive input. Thank you, Lisa. Appreciate it. Thanks, Snowmass. Yeah, so again, going our PICL. Like I said, I'm on that thing 7 days a week. Sometimes sometimes my wife's giving me a little hard time about it. So we'll see how long that lasts. But right now, I'm on it 7 days a week. Can you tell from supine MRI, CT, X-ray if CT rotation is treatable or not via regen when surgeons recommend fusion? Not from that information, no. Well, so supine MRI, it's possible but unlikely. CT scan, possible but unlikely. X-ray, possible but unlikely. You need movement-based imaging for us to determine whether or not you're a candidate for this type of treatment. That means an upright MRI with flexion and extension, a digital motion X-ray. Static imaging is much, much less likely to be helpful. Christy, are you talking about oral blood thinner like Xarelto? Is it possible to switch to Lovenox prior to PICL? Yeah, so we can do a Lovenox bridge, Christy, if you're on an oral blood thinner. So what Christy's talking about is that for patients that are anticoagulated, there's something called a Lovenox or a heparin bridge, where you are taking the patient off of their blood thinners for as short a period as time. So you take them off their oral blood thinners, you put them on some short-acting injectable anticoagulants. Those anticoagulants are not working during the procedure, so you don't get excessive bleeding. And then you restart the injectable anticoagulants and work back in the oral anticoagulant right after the procedure. It's called a Lovenox or heparin bridge. JH Vortex, do you see CCI, AAI patient get a hunch? And when to get yes and no. I mean, we see lots of people with hunches, right? They do this all day. This is really bad. Don't do this all day. I will say that kyphosis or the hunch makes upper cervical and cervical spine in general symptoms much worse. So you got to start working on that. We work with Todd Ball on those sorts of issues, but you got to start working on that right out of the gate because that will really help things. Now, obviously, if we treat your upper neck, maybe it's easier to work on those things, but you got to get rid of that hunch or that forward head position. Catherine, does PICL help cervicomedullary syndrome due to CCI? Catherine, better stated is, so let's go back up a little bit. Cervicomedullary syndrome, just so everyone knows what we're talking about, is when you have the medulla or upper spinal cord, could be either, and the dens put some pressure on that or touches that. Now, that can happen in a retroflex dens. That can happen due to postural changes. That can happen due to instability. When we're treating patients like that, they have instability. Now, they've always had their dens in proximity of their medulla ever since probably they went through puberty, but it's never been a problem. And then they get instability, and it becomes a problem because there's less room there. So we treat those patients by getting rid of their instability, no different than a fusion treats them by getting rid of their instability, right? Most of those patients aren't getting their dens removed because that's a hugely aggressive, invasive type of upper cervical fusion. They're just getting an upper neck fusion with the concept that you're taking away the instability. The instability is causing the banging on the medulla and the symptoms. Same thing with PICL. Getting rid of the instability can reduce the symptoms, whether cervicomedullary syndrome is there or not. Thanks, Trevor. Snowmass, does regen work on fractures? How have skull fractures been treated? We haven't treated any skull fractures. We treated a lot of other non-union fractures, meaning fractures that have failed to heal. It works quite well. Todd Burke, thanks again for the session. I've been needing to ask you about PICL, your treatments of facet joint arthritis. How do you treat that? Yeah, Todd, so the goal of treating facet arthritis is to treat the joint directly. You can inject into those upper neck joints directly. Now, sometimes that can get severe. I think I did a YouTube not too long ago on someone who had a very, very large C1, C2 facet. Hey guys, the questions keep coming, and I am a good 15 minutes over here. I'm just going to take a few more. Please share with other healthcare professionals. I would agree, Natasha. I think that's very important. Tanya, Dr. Markle is fantastic at what he does. Well, thank you so much, Tanya. I appreciate that. And I know he will too. I'm trying to look at questions we haven't answered yet. Hannah, visual issues are usually due to abnormal proprioception coming from the upper neck, affecting the cervical ocular reflex, or COR. Lindsay, we have other doctors continue your procedures after you retire. Absolutely. So already Dr. Schultz has been trained, Dr. Pitts has been trained, Dr. Meckel is getting trained. Just realize that what we do is not a simple thing, right? You can't learn what we do at a weekend course. You can't learn what we do from watching a few procedures. So for example, Dr. Meckel has been training on the EPICL procedure now for months. He's starting to do some of his own cases. He's got access to myself and Dr. Schultz so that he can continuously update those skills. But you can't teach it over a weekend course. So, and I have a whole other Facebook Live on how that's going to happen. Let's see. Athena, this is one I haven't seen before. Have you been able to isolate CCI patients with infection in the brainstem? Athena, if you've got an actual infection in the brainstem, then you need IV antibiotics. I think what you're talking about is maybe some sort of functional medicine concept of maybe there's some sort of infection in the brainstem. But if you've got an actual bacterial infection in your brainstem, then obviously that's a life-threatening condition that requires IV antibiotics emergently, as well as hospitalization, etc. Great to hear, Catherine. Thank you for your confidence. Trevor, C2 syndrome, occipital neuralgia and upper cervical instability, but not a surgical candidate. He has headaches and bowel paresthesias. What's your process from the treatment? He has multiple MRI neurologic consult, but sent to pain management with nerve block, but no change. So that usually is you submit all of your imaging. I pre-review the imaging and then determine whether or not we have enough imaging to decide if you are a CCI and PICL or other type of treatment candidate. If you do, then that gets greenlit for a telemedicine, and that's at Centeno-Schultz.com. So if you go to the Centeno-Schultz website, you can obviously make an appointment there. You can get a telemedicine done. but you need movement-based imaging. So just having a supine MRI or CT scan or a brain MRI is not going to cut it. You need movement-based imaging. So an upright MRI with flexion extension, a digital motion X-ray would be critically important there. And then I can see if we can help. And then obviously if you get greenlit from there, then you can come out and get treatment. Richard, coming to see you on March 4th. Never so excited. Have you seen EPICL helping more? Yeah, Richard, I believe I'm seeing that. We're doing a data analysis right now. The hard part is getting enough of the EPICL patients back in, but I'm now starting to see a steady stream of EPICL patients coming back in, because remember, this is on a 4 to 6 month cycle usually, sometimes longer. So as I see those steady stream of EPICL patients coming back in, my sense is that it's making a jump in their symptom resolution over what we had before. Todd, how does Chiari diagnosis impact your work? Todd, there is a bunch of videos that I have on that. So if you go to my YouTube channel and you just type in Chiari, lots and lots of stuff is going to come up. There's also lots and lots of shorts on that as well. So I'm going to direct you to the YouTube channel on that one, because there's a bunch of those. I'm just trying to get to something we haven't seen before. Yeah, I did see this paper. I looked at it before. One of our social media minders told me to look at it. So this is a paper that looked at corticosteroids basically versus PRP for occipital neuralgia. Seemed to be good PRP. The problem was they only looked at a 3-month time frame. So the problem with that is that steroids are still active in that 3-month time frame. They concluded they didn't see a difference between PRP and steroids. But if you look at steroid versus PRP research, where you start to see the separation is after that 3-month time frame. So regrettably, nice, interesting study, but they didn't look at those patients long enough. So there was no 6-month time frame. There was no 12-month time frame. Why didn't they include those? Probably because it's more expensive to do it. 3-month study with a randomized controlled trial is pretty easy to do. But once you get into 6 and 12 months, it gets very hard to recruit patients, right? Who wants to only be in one group for 6 months? They want to move to the other one if it didn't work. So those are much harder studies to do. So regrettably, not a great study for that reason. Christy, hopefully when we retire, you'll still be researching for clinical patients. Well, thank you, Christy. Yeah, who knows what I'll be doing at that point. And explain the difference between getting... okay, guys, this is probably my last one because I'm about 20 minutes over here, and I think our audience is dwindling because we're an hour 20 minutes right now. Tanya Kim, Dr. Centeno, can you explain the difference between getting treated at CSC, Regenexx Clinic in Broomfield, difference with other Regenexx offices all around the world? Yeah, Tanya, the biggest difference for this patient population is for craniocervical instability is we have no other craniocervical instability site right now but Colorado in the Regenexx system. So that's a huge difference, right? None of those other sites offer the PICL procedure. None of those other sites have been checked out by us for doing high upper cervical injections, et cetera. So I think that's the biggest difference for this population. Okay, guys, thanks so much for watching. Thank you for all the likes. I'll give you one more ping on the like thing. If you enjoyed this content, if you got your questions answered, do me a favor, hit that like button right now, just because that helps other patients find this, right? For every patient that's going to see this, whether it's on Facebook or on YouTube, there's 100 or more patients out there who need this information, who are never going to see it simply because there weren't enough likes there and the algorithm didn't rank it high enough to show it to them. So pay it forward, hit that like button. Thanks so much for watching. Have a great day. We'll be back next Sunday. And like I said before, if you get a chance, join this PICL, our PICL on Reddit. Listen, I know Reddit can be a little dodgy sometimes. I myself have been on Reddit. I'm like, oh my God, this is like the wild, wild west on here. But you don't have to interact in anything else other than this PICL Reddit thread, because it's a great place for Q&A. And I police this very heavily. I'm on it all the time. If anyone gets crazy on here, they're gone. So I know Reddit can be a little nutty at times, but this is a great resource on Reddit because it's allowing me to create 10,000 questions and answers regarding craniocervical instability. So thanks so much for watching. I'll be here next week. And thank you for all the wonderful questions. There are no bad questions. Questions are how patients learn. And I appreciate you giving me the opportunity to try to teach you about some of this stuff. Thank you.